Imagine this constant disruptive guest in your life, atrial fibrillation, AF we call it, where your heart just feels like it's doing this frantic, unsteady drum solo. It's unsettling.
Yeah, really unsettling.
Now add to that the everyday challenge of managing obesity, which, your doctor tells you is actually making your AF even harder to control.
Yeah.
So you find yourself at this crossroads, right, faced with two really different paths forward.
Tough spot.
Exactly.
Mm.
Do you go for like a cutting-edge procedure, a catheter ablation, maybe hoping for a quick reset, or do you really commit to a comprehensive program of lifestyle changes plus daily medication, for a more holistic approach?
Big question. Which path do you choose?
Right. Which one gives you the best shot at getting that heart rhythm back to normal? And maybe just as importantly, what other surprising benefits or, frankly, risks come along with each of those decisions?
That's the core dilemma.
That's the intense, real-world dilemma we're diving deep into today. And we're thinking specifically about someone like our hypothetical listener, let's call her Sarah, who might be navigating exactly this situation right now.
Okay.
So today, we're cutting right to the chase. We're exploring some really groundbreaking new research that shines a crucial light on these very questions, our mission. To extract the most vital insights from a rigorous study known as the PRAGUE-25 Trial.
PRAGUE-25. Got it.
Yeah, this trial had a big, ambitious goal. It wanted to see if a dedicated lifestyle program combined with medication could actually be just as good as catheter ablation for treating AF, specifically in obese patients.
So a non-inferiority trial. That's the term.
Right.
Treating if one's not worse than the other.
Exactly. Could the non-invasive option truly measure up? So get ready, because you're going to gain a crystal clear, really nuanced understanding of what truly works when AF meets obesity. Now, before we break down this really crucial topic, we want to extend a very special thank you to London Heartbeat Z Academy UK. Their invaluable educational support made this deep dive possible. And if you're as curious as we are, and you love exploring new fields, we highly encourage you to check out their vast range of over 150 popular courses. Really impressive stuff.
Over 150. Wow.
Yeah. You can also explore their social media channels, Facebook, Instagram, YouTube, for free regular updates. Make sure you don't miss future amazing discussions.
Good tip.
And for those of you who want to go even deeper, maybe consider their higher-level YouTube membership. You get early access to educational videos and even opportunities for personal chats and guidance sessions.
Personal chats. That's great access.
It really is. They are truly committed to broadening access to knowledge, just like we are here on The Deep Dive. Structural pause. All right, let's get started then. For anyone listening who might not be fully familiar, can you quickly explain what atrial fibrillation actually is? And crucially, why does it become such a bigger concern when we add obesity to the picture?
Absolutely. So atrial fibrillation, or AF, is basically an irregular and often pretty rapid heart rate. This can cause poor blood flow out to the body. It's actually the most common sustained abnormal heart rhythm out there.
Most common, really?
Yeah, affecting an estimated 60 million people worldwide. Huge numbers. Now, here's the critical connection with obesity. Numerous epidemiological studies have clearly shown that obesity is one of the strongest factors predicting who will develop AF.
Strongest? How strong are we talking?
Well, get this. Just a 5 kilodromedal difference in body mass index, it's roughly a 10-15 pound difference for a lot of people, can increase your risk of developing AF by anywhere from 19% to almost 30%.
Wow, 19 to 30% just for that amount of weight. That's a powerful link.
It really is. It's significant.
So, knowing the strong connection, how have we traditionally approached treating AF? And what was missing from the picture, from previous research, that PRAGUE-25 was trying to address?
Okay, so catheter ablation has been a cornerstone treatment for AF for a while now, and it's consistently proven very effective, especially for rhythm control. We've had major trials like the CABANA trial, which showed that ablation led to better rhythm outcomes compared to just relying on antiarrhythmic drugs alone.
Right. CABANA was a big one.
It was. But here's the nuance, the interesting bit. Even in those big trials, obesity was actually really common among the patients. The average BMI in CABANA, for instance, was 30 kilomortis Ranger. So right in the obese range.
Okay.
Yet, and this is the key thing, none of those studies included comprehensive lifestyle modification programs as part of their non-ablation or medical therapy arms.
Huh. That seems like a bit of an oversight given the obesity link.
Exactly. It was a glaring gap, especially since some non-randomized studies, like one called the Legacy study, had already hinted that, significant weight loss could profoundly help keep the heart in a normal rhythm.
So the evidence was starting to build, just not from randomized trials comparing it head-to-head with ablation in this group.
Precisely. The big unanswered question remained. If you actually added a robust, structured lifestyle program to the medication, could it genuinely stand up to ablation? Especially in patients where obesity was clearly a major factor driving their AF.
Okay, so that sets the stage perfectly.
Yeah, and that's precisely why the PRAGUE-25 trial was initiated. It specifically set out to test if combining a comprehensive lifestyle modification program with antiarrhythmic drugs could be a non-inferior alternative, meaning, just as good as, or at least not significantly worse than catheter ablation for these obese AF patients. It was designed as a direct head-to-head comparison to give us that clarity.
That makes so much sense. So with such clear question, how did the researchers go about designing this study? What kind of patients were they looking for to get the most accurate answers possible?
Right, well, to ensure the results were rigorous and unbiased, this was set up as a randomized, multicenter, investigator-initiated, non-inferiority trial. Good credentials. It was conducted across 5 centers in the Czech Republic.
Okay, multi-center. Good.
Yeah, and they had very precise rules about who could participate. They were looking for patients who had symptomatic AF, so AF that was causing symptoms. It could be paroxysmal, meaning it comes and goes, or persistent, or even long-standing persistent AF.
Symptomatic AF, got it.
And crucially, their body mass index, their BMI, had to be between 30 and 40 kilograms a lot. That defines moderate to severe obesity. And of course, everyone had to understand the study and provide signed informed consent.
Okay, so symptomatic AF, BMI between 30 and 40. What about who didn't make the cut? Sometimes the exclusion criteria tell us just as much.
That's a great point. They were careful to exclude patients who had other severe underlying heart conditions that might muddy the waters, like a history of AF causing significant heart muscle weakness that's called tachycardia-induced cardiomyopathy.
Okay, makes sense.
They also excluded those with very extreme obesity, so a BMI greater than 40 kilograms, or very poor heart pumping function specifically, a left ventricular ejection fraction of 40% or less.
So focusing on folks without severe heart failure already.
Exactly. Also out were patients with untreated blocked heart arteries, or very enlarged left atria bigger than 60 millimeter, or anyone who actually needed obesity surgery anyway.
Right.
And to keep the group comparable and focused, they excluded anyone age 75 or older, or those with significant physical limitations that would prevent them from doing the exercise part of the lifestyle program, or anyone who had contraindications for the specific antiarrhythmic drugs being used.
Wow, that's a thorough list. It sounds like they really honed in on a specific group.
They did. It helps ensure they were comparing apples to apples, focusing on a representative group of AF patients where moderate obesity was a key factor.
So once they found these eligible patients, how did they ensure the comparison between the two treatment groups, ablation versus lifestyle plus drugs, was actually fair?
It all came down to randomization. That's the gold standard. Eligible patients were split completely randomly, 1-to-1, into either the catheter ablation group or the lifestyle modification plus antiarrhythmic drugs group.
1-to-1, okay.
Yeah, and they used a web-based system to make sure it was truly random. Plus, they did something called stratification. They made sure to balance the groups based on initial BMI, sex, and the type of AF the patient had. That just adds another layer of confidence that the groups started out as similar as possible.
Sure.
And importantly, all patients were also fully informed about the specific risks of obesity related to AF. That's vital for proper informed consent.
Absolutely. And before any treatment actually began, what baseline information did they gather? What did they measure on everyone at the start?
Good question. Within 4 weeks of being randomized, every single patient underwent a really comprehensive set of baseline tests. This included a cardiopulmonary exercise test, or CP.
CP, okay. What does that measure?
It's a great way to measure their physical fitness level, basically their peak oxygen uptake, and see how their heart and lungs respond to exertion. They also had echocardiography and ultrasound of the heart to get a detailed look at its structure and function.
Standard stuff, yeah.
Right. And they completed a specific questionnaire called the Atrial Fibrillation Effect on Quality of Life Questionnaire, or AF-EQT. That gave a baseline score for their quality of life related to AF. Standard blood tests were done too. And critically, everyone wore a 7-day ECG Holter monitor.
Ah, the Holter monitor, to see their baseline rhythm.
Exactly. To get a clear picture of their heart rhythm over a full week and, importantly, quantify how much time they were actually spending in AF before any treatment started. This rich baseline data was crucial for making accurate comparisons later on. Structural pause.
So patients are randomized, baseline data collected. Now they embark on these truly distinct therapeutic journeys. Let's trace those paths, starting with the catheter ablation group. What did their treatment look like?
Okay, for the catheter ablation, or CA group, patients typically had their procedure pretty quickly, within about 6 weeks of randomization. Standard practice was that every patient received what's called pulmonary vein isolation, or PVI.
PVI, that's the standard target in AF ablation, right?
That's the foundational step, yeah. Targeting the areas around the pulmonary veins, where those rogue electrical signals often kick off AF. Now, for about 35% of those who had the more persistent types of AF, non-paroxysmal AF, they received additional ablation lesions beyond just the PVI, as the operator thought necessary.
Okay.
Now, here's a really key detail. The first 3 months after the ablation procedure were designated as a blanking period.
A blanking period, what's that about?
Think of it like a healing or settling down period for the heart tissue after the ablation. During these first 3 months, any AF episodes that occurred were not counted as a treatment failure in the study's main analysis.
Okay, so gives the heart time to recover.
Exactly. Because some inflammation and irritability is expected right after the procedure.
Yeah.
Antiarrhythmic drugs or even electrocardioversions were allowed during this blanking period if needed to manage symptoms. But, and this is important, they had to be stopped before the end of those 3 months.
Got it.
The crucial part for the study's definition of success was this. If a patient needed to restart antiarrhythmic drugs after that 3-month blanking period because their AF came back, that was officially counted as a treatment failure for the primary outcome.
Okay, clear definition there. So what about the other group? The lifestyle modification plus antiarrhythmic drugs, or LFM plus AAD group. This sounds like a much more involved, holistic approach, probably requiring a lot more from the patient day to day.
It really was a very different commitment. The full program for this LFM plus AAD group began within 4 weeks of randomization. And crucially, this wasn't just the doctor saying you should try to lose some weight.
Right, not just a pamphlet.
Definitely not. The LFM aspect was actively managed by dedicated specialized teams of dietary specialists and physiotherapists. Importantly, not the treating cardiologists. This meant patients got expert-focused guidance, specifically on the lifestyle changes.
Dedicated teams. Okay, that makes a difference.
Huge difference. Patients had initial, really in-depth consultations with these specialists. They were also strongly encouraged to use a specific mobile phone application called obese.
obese, what did that do?
It was a tool designed to help them meticulously record their daily calorie intake and their exercise activity. It gave them a practical way to track their progress and stay accountable, and likely communicate with the specialists, too.
So they had specialized support and tools. What did the actual lifestyle changes involve day to day?
Patients were given clear instructions and, importantly, consistent encouragement to reduce their calorie intake. They were also guided to decrease alcohol consumption, although complete abstinence wasn't strictly required.
Okay, calorie reduction, less alcohol. What about activity?
For physical activity, the physiotherapist created individual exercise programs. These were tailored to each patient's specific fitness level, based on those baseline CPA results we talked about.
Personalized exercise plans, nice.
Yeah. And to help them stick with it and exercise safely, patients monitored their heart rate during exercise using fitness bands. Now, as for the AD part, the antiarrhythmic medication.
Right, they were getting drugs too.
Yes. These drugs were started within 4 weeks of randomization, and doctors could adjust the dosages during the first 3 months to find what worked best for each patient. The specific choice of AD, the drug itself, depended on local practice in the Czech Republic, but typically Class 1C drugs like propafenone or flecainide were first line. Amiodarone, which is a stronger drug with more potential side effects, was reserved as a third-line option if the others failed.
Okay.
And here's a key difference from the ablation group. Patients in this LFM plus AAD group were allowed to continue taking these antiarrhythmic drugs throughout the entire follow-up period of the study.
So they could stay on meds long-term, unlike the CA group post-blanking.
Exactly. They also had a similar 3-month blanking period at the start, where early AF wasn't counted against the treatment. And it's worth mentioning that standard medical care managing things like blood pressure, cholesterol, diabetes was handled consistently in both groups by their regular cardiologists or diabetologists. That wasn't part of the specific intervention being tested.
Okay, so 2 very distinct approaches, both with careful monitoring. Once treatments were underway, how did the researchers keep tabs on these patients over time, and how did they actually define success or failure?
They had a very structured follow-up schedule. Patients came in for outpatient visits at 3, 6, 9, and 12 months initially, and then every 6 months after that.
Regular check-ins.
Yep. And at that 3-month visit, remember, just after the blanking period, any patient in either group who was found to still be in AF actually underwent an electrical cardioversion to try and shock them back into normal rhythm.
Okay, intervention there if needed. And how did they track the AF itself?
Primarily through those 7-day Holter recordings. These were done every 3 months during the first year and then every 6 months afterwards. And crucially, these recordings were evaluated by independent readers who were blinded.
Blinded, meaning they didn't know which group the patient was in?
Exactly. They didn't know if they were looking at a recording from an ablation patient or a lifestyle patient. This is really important to help eliminate any potential bias in interpreting the results.
Makes sense. So what was the ultimate goal? The primary endpoint?
The primary endpoint, the main thing they were measuring to judge success, was defined very precisely. The absence of any atrial tachyarrhythmia. That includes AF, atrial flutter, or atrial tachycardia. Any of those rhythms lasting more than 30 seconds.
Okay.
Specifically during the 1 year following that initial 3-month blanking period. So they were looking for sustained rhythm control in that year window. This was assessed using all those Holter recordings, plus any ECGs taken during clinic visits and any documented AF that happened during unplanned hospital visits or ER trips.
Rigorous definition. What about other measures? Secondary endpoints?
Yeah, they looked beyond just AF freedom to get a broader health picture. These secondary endpoints included changes from baseline to 12 months and things like AF burden, that's the percentage of time a patient actually spends in AF.
Okay, not just yes, no, but how much AF?
Right. Also, peak oxygen uptake, that VO2 max measure from the CPT to see changes in physical fitness. Quality of life scores using that AFUT questionnaire, and several pre-specified metabolic parameters. Body weight, lipid levels, cholesterol, triglycerides, and glycated hemoglobin, or HbA1c, which is that key marker for diabetes control.
This level of detail in the design is really impressive. It gives us a lot to think about. Let's bring back our hypothetical listener, Sarah. Remember, she's 62, has persistent AF, BMI of 36. Now that she's heard all about how this trial was set up, the 2 different treatment paths, the monitoring, what would be going through her mind right now as she weighs these options?
Yeah, for Sarah, this information makes the decision incredibly real, doesn't it? It highlights that initial dilemma perfectly. On one hand, she sees the catheter ablation path. It might feel like a more direct hit on the AF itself. Maybe she's thinking, okay, it's a procedure, there's a recovery period, but maybe then the AF is just gone, and I can potentially get off these rhythm drugs. It might seem like a faster, more definitive fix for the palpitations and fatigue that are bothering her right now.
The appeal of a direct intervention, a fundamental shift, really.
A fundamental shift in daily life. So she'd be weighing that invasive procedure, which holds the promise of faster rhythm control, against this sustained holistic effort. An effort that might improve her entire health picture, weight, fitness, maybe blood sugar, but requires daily actions and staying on medication, possibly long-term. It's a profound choice between a targeted attack on the AF and a broader investment in overall health, each demanding a lot in different ways. Structural pause.
Okay, the stage is perfectly set. We understand the patients, the 2 treatments, the goal. So the big question, what did the PRAGUE-25 trial actually discover when they analyzed all that data? What were the main outcomes?
All right, let's get into the results. So the trial started with 212 patients randomized. After a few early withdrawals for various reasons, they ended up analyzing 203 patients, 100 in the catheter ablation group and 103 in the LFM plus AAD group.
Pretty balanced groups then.
Yeah, very well balanced. The average age was around 60, about a third, 31.5% were female, and the average BMI was 34.9 kilodrometers arts, so squarely in the obese category as intended. Just over half had paroxysmal AF, the type that comes and goes.
Okay. And how long did they follow them?
The mean follow-up time was 23.5 months, so almost 2 years on average. That gives a really good window to see how things played out. Now, here's an interesting finding right off the bat. 26 patients actually crossed over from their assigned group to the other group during the study.
Crossed over, meaning they switched treatments.
Exactly. And get this. Nearly all of them, 25 out of the 26, moved from the LFM plus AAD group to the catheter ablation group.
Wow, almost entirely one-way traffic. What does that suggest?
Well, it strongly suggests that either the lifestyle and drug approach wasn't working well enough for those patients, or perhaps they simply preferred to try the ablation after giving the other approach a shot. It hints at potential issues with effectiveness or patient satisfaction in the LFM plus AAD arm for some individuals.
Fascinating detail. Okay, so let's break down what actually happened within each treatment group during that follow-up period. Start with the ablation group again.
Sure. In the catheter ablation CA group, as we said, all patients got PVI. About 35% with non-paroxysmal AF got additional lesions. Interestingly, they used both common ablation technologies. 48 patients received radiofrequency ablation, and 51 received pulsed field ablation, which is a newer technique.
Good mix of technologies there. How effective was it? Did people need repeat procedures?
Actually, the redo rate was quite low. During the follow-up, only 7% of the CA group needed a repeat ablation procedure because their AF came back. That's pretty good. And at the 12-month mark, only 16% of the CA patients were taking antiarrhythmic drugs, presumably because of documented AF recurrences after the blanking period.
So mostly off drugs, good rhythm control for the majority. What about their weight? Did the ablation itself have any impact?
That's another interesting point. In terms of weight, there was really only a very small, non-significant reduction in body weight in the CA patients. We're talking an average of about 0.35 kilograms less than a pound at 12 months. So the procedure itself didn't lead to weight loss.
Okay, so ablation fixes the rhythm for many, but doesn't touch the weight aspect. Now, what about the LFM plus AAD group? This is where we'd expect to see different kinds of changes.
Precisely, and this is where the contrast becomes really stark, especially when you look at the metabolic side. This group saw a highly significant reduction in body weight. On average, they lost 6.37 kilograms. That's roughly 14 pounds at the 12-month mark.
14 pounds, that's substantial.
It is. And critically, the data showed this weight loss was actually maintained when they looked again at 24 months. So it wasn't just a temporary drop.
That's impressive sustainability. Were they using weight loss drugs like GLP-1 agonists much?
That's a good question. Those drugs weren't systematically given as part of the protocol. However, about 14.6% of patients in this group did end up using them, usually liraglutide or semaglutide, for a period typically around 6 months on average. But the majority of the weight loss seems attributable to the lifestyle program itself.
Okay. And they were on rhythm drugs too.
Oh yes, antiarrhythmic drug use was high, as planned. 95.1% were on AADs at the 3-month mark, primarily those class 1C drugs, propafenone or flecainide. And here's a big testament to their engagement with the lifestyle part. Based on questionnaires, 64.1% reported they decreased their alcohol consumption. A really impressive 76.7% said they increased their physical activity.
Over 3/4 increased activity.
Yeah. And 66%, 2/3, reported regularly using that obese mobile app to track their progress and presumably interact with the support team, shows real commitment from many in that group.
Those are really high adherence rates for lifestyle changes, which can be notoriously difficult.
Okay, so we've got the picture. One group got a procedure, largely controlled rhythm, stayed about the same weight. The other group made significant lifestyle changes, lost weight, stayed on meds. What was the final verdict on the study's primary question? Which strategy achieved more freedom from AF?
This is the absolute headline finding from PRAGUE-25. At the 12-month mark, freedom from AF, remember, no episode over 30 seconds after the blanking period was achieved in a striking 73.0% of patients in the catheter ablation group.
73%, okay.
Now, compare that to the lifestyle modification plus antiarrhythmic drugs group. In that group, only 34.6% of patients achieved AF freedom by the same definition.
Wow, less than half the rate, 73 versus 35% roughly. Exactly, a huge difference. The statistical analysis was unambiguous. The criteria for non-inferiority, that idea that LFM plus AAD might be just as effective as CA, were clearly definitively not met.
Not even close to non-inferior then.
Not even close. In fact, because non-inferiority wasn't met, they then tested for superiority. And the result? Catheter ablation was found to be statistically superior to LFM combined with AADs for achieving AF freedom at 12 months. The p-value was less than 0.001.
P less than 0.001. For listeners, that means highly statistically significant, right? Very unlikely this result is due to chance.
Extremely unlikely. It's a very robust finding. And the superiority of ablation held true consistently across all the different patient subgroups they looked at. Didn't matter if it was paroxysmal or persistent AF, male or female, different BMI levels within the range. Ablation was consistently better for rhythm control, structural pause.
So the primary outcome is crystal clear. For purely achieving freedom from AF, catheter ablation was the hands-down winner in this study. But as you mentioned earlier, this study looked at so much more than just the heart rhythm itself. What did it reveal about the patient's overall health, their fitness, their metabolic status, quality of life?
That's such a vital distinction to make because health isn't just one thing, right? It's multifaceted. So looking at those secondary outcomes, we see a more complex picture emerge. First, regarding AF burden, the actual percentage of time spent in AF, while CA was superior for achieving complete freedom from AF, the AF burden itself actually decreased significantly in both groups at 12 months compared to where they started.
So even the LFM plus AAD group had less AF overall, even if fewer were completely free of it.
Exactly. Both strategies reduced the amount of AF patients experienced. Now, physical fitness, measured by that peak oxygen uptake, the VO2 max on the exercise test, here we saw a significant increase in fitness in the LFM plus AAD group. Their VO2 max went up by about 1.14 mmN per kilogram on average.
So the lifestyle group actually got fitter.
They did, demonstrably fitter. Interestingly, this fitness measure remained pretty much unchanged in the catheter ablation group. However, when they compared the change between the two groups, that difference didn't quite reach statistical significance.
Interesting. So LFM improved fitness, CA didn't, but the difference between them wasn't statistically solid. Okay. But let's talk metabolic health. This feels critical given the focus on obesity. What did they find there?
This is arguably one of the most crucial findings of this study, where the LFM plus AAD group really stood out. Let's talk about HbA1c concentrations. Remember, that's the key indicator for long-term blood sugar control and diabetes risk.
Right, the A1C test.
In the LFM plus AD group, HbA1c levels significantly decreased by an average of 1.4 millimole. That's a meaningful improvement in blood sugar control. But here's the really surprising contrast. In the catheter ablation group, HbA1c concentrations actually increased slightly by an average of 2.5 millimole.
Wait, they increased in the ablation group, so their blood sugar control got slightly worse.
On average, yes. And this resulted in a statistically significant difference between the two groups at 12 months, clearly favoring the LFM plus AAD approach for this key metabolic marker.
Wow, that's a major divergence. What about other metabolic markers like cholesterol?
Other markers like total cholesterol and triglycerides also showed some positive trends, generally improving more in the LFM plus AAD group, although the statistical significance of the difference between the groups wasn't always as strong as it was for HbA1c. But the overall metabolic picture definitely favored the lifestyle intervention group.
Okay, so LFM plus AAD wins on weight loss, wins significantly on blood sugar control, improves fitness. What about how patients felt? Quality of life.
This is perhaps the most counterintuitive finding of all. Quality of life was assessed using that AFUK questionnaire. And despite the huge difference in AF freedom rates, with CA being much better.
You expect the CA group to report feeling much better, right?
You'd think so. But surprisingly, both groups reported similar, significant improvements in their quality of life scores from baseline to 12 months. There were no statistically significant differences between the groups and how much their quality of life improved.
That's fascinating. So even though the LFM plus AAD group had more AF recurrences, they felt just as much better overall as the group that got ablation.
That's what the data suggests. It really makes you question what drives a patient's perception of their health and the success of a treatment. Maybe the weight loss, the improved fitness, the feeling of empowerment from the lifestyle changes counterbalance the ongoing AF for the LFM group. It's a really important point about looking beyond just the primary disease outcome.
A truly powerful insight. Okay, let's pivot to safety. Procedures and drugs always carry risks. What did this study find regarding complications in both groups?
Safety is always paramount. In the catheter ablation group, the rate of clinically relevant major complications was remarkably low. It occurred in only one patient out of 100, so 1%.
Only 1%. That's very low for an invasive heart procedure.
It is. This patient experienced a transitory ischemic attack, or TIA, essentially a mini-stroke, during the procedure itself. But thankfully, it was temporary. This finding really reinforces the steadily increasing safety profile of modern catheter ablation techniques, even in an obese population, which can sometimes pose technical challenges.
That's reassuring for ablation. What about the LFM plus AAD group? They were taking daily medications.
This is where the safety profile looks different, and frankly more concerning. In the LFM plus AAD group, major drug-related adverse events were observed in 4 patients out of 103, which comes out to 3.8%.
Okay, 3.8% major drug events versus 1% major procedural event. What kind of events?
3 of these patients experienced syncope, which is fainting spells, likely related to the heart rhythm or the medication's effect on blood pressure. But tragically, 1 patient in this group died suddenly and without a clear explanation. This was classified by the study investigators as sudden cardiac death, or SCD.
Sudden cardiac death, while on the antiarrhythmic medication.
Yes. This patient was being treated with propafenone, one of those class 1C drugs, at the time. This incredibly grim outcome serves as a stark reminder that antiarrhythmic drugs, especially the class 1C agents, do carry a small but real risk of proarrhythmia, causing dangerous rhythms and sudden cardiac death. This risk exists even in patients who might otherwise seem relatively healthy or don't have other obvious structural heart disease.
That's a very heavy point to consider, a rare but devastating potential side effect of the medication itself. It really highlights the different risk profiles. Okay, let's bring in another case example. Let's consider David, another hypothetical listener, who chose the LFM plus AAD path. Maybe his AF wasn't completely gone at 12 months like many in that group, but based on these secondary outcomes, what kind of metabolic benefits might he be celebrating? And what does that really mean for his overall health journey, looking beyond just the AF freedom?
David's story is a perfect illustration of the, let's call the broader victory that the lifestyle approach can offer, even if it doesn't win on the primary AF endpoint. So, okay, maybe David still has some occasional AF episodes, but by committing to that structured LFM program, he likely achieved significant weight loss. Remember that average of over 6 kilograms, 14 pounds.
Right.
And perhaps even more importantly, he dramatically improved his HbA1c levels, his blood sugar control. For David, this translates into a much lower risk down the road for developing full-blown type 2 diabetes, or if he already had it, preventing it from getting worse. It also lowers his risk for other serious obesity-related conditions, things like heart failure, kidney disease, maybe even certain cancers, and definitely future cardiovascular events like heart attacks and strokes.
So the benefits ripple outwards far beyond just the AF.
Exactly. So while his heart rhythm might still be, let's say, a work in progress, his overall long-term cardiovascular health trajectory has likely taken a significant positive turn. And that's an enormous win. It's a win that will likely benefit him for years, potentially decades to come. It truly demonstrates that success in medicine isn't always black and white, defined by a single endpoint. For patients like David, the improvements in weight, fitness, and metabolic health might be just as or even more valuable in the long run. Structural pause.
Okay. We have the core results. Catheter ablation clearly won the race for AF freedom, but as we've just unpacked, that is definitely not the whole story. So let's try to interpret these findings. What's the bigger picture here? How do these PRAGUE-25 results fit in with other research we know about? And what did the study authors themselves acknowledge as the limitations of their work?
Right, putting it in context is key. The finding that catheter ablation was superior for AF freedom isn't actually that surprising in itself. It aligns perfectly with what other major randomized controlled trials, like Cabana, have shown previously.
Yeah.
It really reinforces that, for pure rhythm control, ablation is a very powerful tool.
Consistent with previous evidence, then.
Yes. Now, this contrasts a bit with some non-randomized studies, like that Legacy study we mentioned earlier. Legacy showed really promising results with significant weight loss from lifestyle modification. But the criticism there is always selection bias. Maybe only the most highly motivated patients participated and succeeded in those non-randomized settings.
Right. Harder to generalize from those.
Exactly. We also had another randomized trial called SORT-AF. It also looked at weight loss in AF patients, but the weight loss achieved after ablation in that trial was more modest, and they didn't find a significant difference in AF burden specifically from the weight loss component. So PRAGUE-25 adds crucial context by directly comparing a structured LFM program head-to-head with ablation from the start.
Okay. And speaking of the weight loss in the PRAGUE-25 LFM plus AAD group, they achieved over 6 kilograms on average. That sounds pretty good, but you mentioned the trial had aimed for 10%. Was the 6.37 kilograms maybe not enough weight loss to really impact AF freedom more?
That's a really important question the authors grapple with. The average 6.37 kilogram reduction, while statistically significant and notably maintained at 24 months, was indeed less than the ambitious 10% target they'd set. It was similar to the middle group in the Legacy study. It seems like a fair assumption, based on other data like Legacy, that greater weight loss, maybe hitting that 10% or even 15% mark, would likely lead to even better outcomes for AF freedom itself.
So maybe the LFM plus AAD arm could have done even better on AF freedom if they'd achieved more weight loss.
It's certainly plausible. It also raises the question about tools like the GLP-1 agonists, those weight loss medications.
Yeah.
They weren't systematically used here. While they are very effective for weight loss, it's interesting that recent meta-analyses haven't shown a significant direct impact of these drugs on AF incidence itself, separate from the weight loss effect. So it's complex.
So if maybe more weight loss could have helped, are there other reasons why the AF freedom rate in the LFM plus AAD group at around 35% was still maybe lower than some might have expected, even compared to other medication-only trials?
Yeah, there are a few potential contributing factors discussed. One possibility is that the class 1C antiarrhythmic drugs Remember, propafenone and flecainide were used in 74% of the LFM patients, might simply be less effective at controlling AF in individuals who have obesity. There is some physiological basis to suspect that.
Okay, drug effectiveness might be lower in this group.
Second, as we just discussed, the moderate level of weight reduction achieved, while good, might just not have been enough to fully reverse the underlying structural and electrical changes in the heart, the atrial remodeling that obesity causes and that drives AF.
The damage might have been too advanced in some.
Possibly. And that ties into the third point. The very fact that these patients already had manifest symptomatic AF might indicate they were already at a more advanced stage of the disease process. If so, the effectiveness of any preventive program, including lifestyle modification, might be somewhat limited once AF is firmly established. It might be harder to turn back the clock at that point.
That makes sense. Okay, let's flip back to the ablation group. You highlighted the remarkably low complication rate. Does this trial further cement the idea that catheter ablation is becoming a safer procedure, even in these potentially more challenging obese patients?
I think it absolutely does. That low major complication rate of just 1% for a temporary TIA is really quite striking. It underscores the continuous improvements we've seen in ablation technology, techniques, and operator experience over the years. And importantly, it shows this safety profile holds up even in obese patients, where things like vascular access for the catheters can sometimes be trickier. The study notes they used ultrasound guidance for vascular access, which likely helped minimize those specific risks.
Good practice paying off.
Yeah. And similar low complication rates were also seen in obese patients in that SORT-AF trial recently. So it seems to be a consistent finding now. Ablation is getting safer.
That's definitely reassuring news. But we have to come back to the risks on the other side. The serious adverse events linked to the antiarrhythmic drugs in the LFM plus AAD group. Can you elaborate a bit more on why that 3.8% rate, including the sudden death, is such an important consideration when weighing these options?
This is a critical part of the risk-benefit discussion, and it really raises an important question when comparing the two treatments directly. That higher rate of major adverse events, 3.8% in the LFM plus AD group, driven primarily by drug side effects including syncope, and most tragically, that one sudden unexplained death, cannot be ignored.
It really puts the risks of daily medication into sharp focus.
It does. While antiarrhythmic drugs are a mainstay for managing symptomatic AF, their associated risks need to be very carefully considered and discussed with patients. The Class 1C drugs, in particular, carry that known, albeit small, risk of proarrhythmia and sudden cardiac death. Sometimes these drugs can unmask underlying, previously unrecognized conditions, like silent coronary artery disease or subtle electrical abnormalities in the heart, like Brugada syndrome or long QT syndrome. So even in AF patients who seem otherwise healthy, these drugs aren't entirely benign. It underscores that every treatment choice, whether it's a procedure or a pill, comes with its own unique set of potential risks that have to be weighed against the potential benefits.
A crucial point about weighing risks and benefits, but let's not lose sight of the flip side for the LFM plus AA group. Despite the lower AF freedom rate and the drug risks, they had those significant metabolic and fitness improvements. Let's make sure we truly underscore those unsung benefits, as you called them earlier.
Absolutely, because this is arguably the most important practical implication of the study for patients and doctors. Despite not winning on AF freedom, the LFM plus AAD group experienced profound, positive changes in their overall health profile. Let's recap them. A significant decrease in body weight, major improvements in metabolic parameters, especially that impressive drop in HbA1c, and even an improvement in physical performance, the increased peak VO2.
So why does that collection of benefits matter so much in the long run?
Because these factors are hugely predictive of long-term health. We know that higher HbA1c levels and higher body weight are strong, independent risk factors for major future cardiovascular events, heart attacks, strokes, heart failure, hospitalization, and even overall mortality, dying earlier. Conversely, achieving significant weight reduction and improving cardiorespiratory fitness, like the LFM group did, are consistently linked to better long-term cardiovascular outcomes and longer life expectancy.
So these changes directly impact future health risks.
Directly and significantly. And remember that quality of life finding. The improvements were similar in both groups. This suggests that patients in the LFM group perceive the benefits of weight loss, better fitness, and perhaps feeling more in control of their health, just as positively as the CA group perceived the benefit of better rhythm control.
It's about the overall sense of well-being.
Exactly, which leads to the study's crucial conclusion. The authors explicitly state that the reduced effectiveness of LFM plus AAD for achieving AF freedom should not dissuade obese patients from pursuing weight loss and lifestyle modifications. Why? Because of these other very real, significant long-term cardiovascular benefits. The message isn't don't do lifestyle changes, it's lifestyle changes are crucial for overall health, even if ablation is better purely for rhythm control. It's about promoting comprehensive cardiovascular health, not just tackling one symptom or condition in isolation.
That's a really powerful and nuanced takeaway. Okay, now, every study has its limitations, things the authors acknowledge could have affected the results or how we interpret them. What were the main limitations mentioned for PRAGUE-25? What should we keep in mind?
Definitely. No study is perfect, and acknowledging limitations is key to good science. Firstly, as we discussed, those GLP-1 agonist weight loss drugs were not systematically used. And even with the dedicated program, the LFM plus AAD group didn't quite hit that ambitious 10% weight reduction target on average.
And more weight loss might have meant better AF outcomes.
Possibly, given that other, albeit non-randomized, studies showed a stronger link between greater weight loss, like 10% or more, and AF freedom, it's conceivable that achieving more substantial weight loss might have narrowed the gap in AF outcomes between the LFM group and the ablation group. We can't know for sure from this data, but it's a plausible hypothesis. Another point is timing. It's possible that the positive effects of weight loss on the heart's structure and electrical function, the reversal of that atrial remodeling, might take longer to fully manifest than the 12-month primary follow-up period of the study. Maybe the benefits for AF freedom in the LFM group would have continued to accrue if they'd followed patients for, say, 3 or 5 years as the primary window.
So 12 months might have been too soon to see the full LFM effect on AF.
It's a possibility. Then there's the way they monitored heart rhythm. They used 7-day Holter recordings every few months. While that's pretty good, it's not continuous monitoring. Implantable loop recorders, which track rhythm 247 for years, were not used. So it's possible that some shorter, perhaps asymptomatic AF episodes might have been missed in both groups. Using loop recorders might have given an even more precise picture of AF burden.
Okay, monitoring method is a point. Anything else?
A couple more technical points. The initial calculation for the study's size, the power analysis, actually anticipated slightly different success rates than what they found. They expected maybe 60% success for CA and hoped for 65% for LFM plus AAD to show non-inferiority. Since the actual rates were quite different, 73%, 35%, the study might not have been perfectly powered to definitively rule out any possibility of non-inferiority under slightly different assumptions, although the observed difference was huge.
A statistical nuance there.
Yeah. And finally, while the LFM program focused intensely on weight, alcohol, and physical activity, other known AF risk factors like smoking cessation, aggressive treatment of obstructive sleep apnea, and really strict blood pressure control weren't specific, protocolized interventions within the LFM arm. They were managed as part of standard care for everyone, but perhaps an even more comprehensive risk factor modification program could have yielded different results. Also, the exact amount of exercise activity wasn't meticulously measured with accelerometers or anything, just reported by patients.
Got it. These limitations are important context. This nuanced understanding is exactly what we aim for on the deep dive. So let's bring Sarah back one last time. Our 62-year-old listener with persistent AF and a BMI of 36. Knowing everything we've discussed now, CA's superiority for AF freedom, but LFM plus AAD's significant metabolic benefits, improved fitness, similar QL improvement, but also the AAD risks. How might she make her decision? What's the real-world, practical application of all this complex data for someone in her shoes?
This is where it all comes together, right? It underscores why personalized medicine and shared decision-making between the patient and their doctor are absolutely paramount. For Sarah, this information clarifies that her decision isn't a simple binary choice based on one outcome. It's a preference-sensitive decision.
Preference-sensitive, meaning it depends on what she values most.
Exactly. If her primary overriding goal is to get her heart rhythm as stable as possible, to maximize her chances of being free from AF and potentially off-rhythm drugs, and she's willing to undergo an invasive procedure to achieve that, then catheter ablation emerges as the clearer choice for that specific outcome. The data strongly supports its superiority there.
Okay, if AF freedom is #1, lean towards CA.
But if Sarah's biggest concern is her long-term overall health, if she's really worried about her risk of diabetes, future heart problems, her weight, her fitness level, she might still lean strongly towards the lifestyle modification path, even knowing her chances of complete AF freedom are lower. She might decide that the significant weight loss, the improved blood sugar control, The better physical fitness and the overall sense of well-being are more valuable to her, even if it means managing some ongoing AF with medication.
So she might prioritize the metabolic wins over complete rhythm control.
She might. It highlights that there's no single best path for everyone. It depends entirely on her personal priorities, her values, her tolerance for procedural risk versus medication risk, her willingness and ability to commit to sustained lifestyle changes versus undergoing a procedure. It's a conversation she needs to have with her doctor, armed with this kind of nuanced data, to figure out what aligns best with her unique health goals and life circumstances.
And maybe it's not even an either forever.
That's the final provocative thought, isn't it? Perhaps the ideal approach for some patients, maybe even Sarah down the line, might involve a sequence or a combination of strategies. Maybe start with intensive lifestyle modification for those crucial metabolic benefits, and if AF remains highly symptomatic despite that, then consider ablation, or maybe pursue both concurrently. The future might lie in more tailored adaptive strategies over time. Structural pause.
Wow. What an incredible deep dive into the PRAGUE-25 trial. This study really truly puts into perspective the multifaceted nature of treating complex conditions like atrial fibrillation, especially when it occurs in the context of obesity.
It really does. And if we connect this back to the bigger picture of medicine, it's such a powerful reminder that medical decisions are rarely, if ever, about a single, isolated outcome. While one treatment, like ablation here, might be definitively superior for a specific condition endpoint like AF freedom,
Right.
another approach, like the intensive lifestyle modification, might offer these crucial, broader health benefits that fundamentally improve a patient's long-term well-being, their future health risks, and their overall quality of life, even if it doesn't win on that one specific measure.
So what does this all mean for you, our curious listener, grappling with similar issues or just trying to understand? It means that informed choices are absolutely paramount. Having these kinds of detailed discussions, talking about all the potential outcomes, everything from AF freedom, yes, but also metabolic health changes, fitness, quality of life, and importantly, the different safety risks, discussing all of that with your healthcare provider is key.
Couldn't agree more.
That's how you find the path that aligns best with your personal health goals and values. And as we just touched upon, maybe the ideal approach for some people might even involve a sequence or combination of strategies over time. That's definitely something to mull over. Okay, now let's see how much of this fascinating information really stuck. We've got some quick fire questions for you. Think of this as a mini challenge to test your recall. Don't worry, we'll give you the answers right after each one. Ready?
Let's do it.
All right, first question. What percentage of patients in the catheter ablation group achieved AF freedom at 12 months in the PRAGUE-25 trial? Was it A, 34.6%, B, 50.0%, C, 73.0%, or D, 90.0%?
Okay, the answer there is C, 73.0%. That really highlights the clear effectiveness of catheter ablation for rhythm control in this specific study population.
Got it. Question 2, about who got into the study. Which body mass index BMI range was required for patient enrollment in the PRAGUE-25 trial? Was it A, 25-30 kilometer at B, 30-40 kilometer at X, C, 40-50 kilometer rate, or D, any BMI as long as the patient was obese?
That one was B, 30-40 kilometer of around. The study specifically focused on patients within that range of moderate to severe obesity to make the comparison.
Perfect. Question 3. What was the precise definition of the study's primary endpoint, AF freedom? Was it A, absence of any AF episode lasting 60 seconds during the blanking period, B, absence of any atrial tachyarrhythmia lasting 30 seconds during the 1 year after the blanking period, C, complete resolution of all cardiac symptoms, or D, maintenance of normal sinus rhythm without any medication?
The correct answer is B, absence of any atrial tachyarrhythmia lasting 30 seconds during the 1 year after the blanking period. That strict definition, focusing on sustained freedom after initial recovery, was key.
Excellent. Question 4, a key point on metabolic health. Which group in the PRAGUE-25 trial experienced a significant average weight reduction at 12 months? Was it A, the catheter ablation, CA group, B, the lifestyle modification with antiarrhythmic drugs, LFM plus AAD group, C, both groups equally, or D, neither group?
That was clearly B. The lifestyle modification with antiarrhythmic drugs, LFM plus AAD group, they showed that significant average weight reduction of about 6.37 kilograms, a core part of their intervention success.
Right. Question 5, the big conclusion on superiority for AF freedom at 1 year. What did the PRAGUE-25 trial find? Was it A, LFM plus AAD was non-inferior to CA, B, LFM plus AAD was superior to CA, C, CA was non-inferior to LFM plus AAD, or D, CA was superior to LFM plus AAD?
The answer is D. CA was superior to LFM plus AAD. Remember, they tested for non-inferiority first, didn't find it, and then found that ablation was actually significantly better for achieving AF freedom.
Exactly. Question 6, digging into those broader health benefits again. Which specific metabolic parameter significantly improved more in the LFM plus AD group compared to the CA group at 12 months? Was it A, total cholesterol, B, triglycerides, C, HbA1c concentrations, or D, N-terminal pro-B type natriuretic peptide?
The standout metabolic improvement was C HbA1c concentrations. The LFM plus AAD group saw that significant decrease, indicating better blood sugar control, while the CA group actually saw a slight increase. A major difference.
Crucial difference. Question 7, remembering the tools. What was the name of the specific mobile phone application used by patients in the LFM plus AAD group to record calorie intake and exercise activity? Was it A, Fitbit, B, MyFitnessPal, C, OBEFS, or D, Heartbeat Tracker?
That specific app was C OBEFS. It was used to support patients in tracking their diet and activity for the lifestyle program.
OBEFS, got it. Question 8, thinking about patient engagement. What was the approximate percentage of patients in the LFM plus AAD group who reported increased physical activity? Was it A, 16.5%, B, 34.6%, C, 64.1%, or D, 76.7%?
That impressive number was D, 76.7%. Shows really high reported adherence to increasing physical activity in that lifestyle intervention group.
Fantastic adherence. Question 9, the surprising quality of life finding. How did quality of life, as assessed by the AFUQT scores, change in both groups from baseline to 12 months? Was it A, significantly improved only in the CA group, B, significantly improved only in the LFM plus AAD group C, showed similar significant improvements in both groups, or D, showed no significant improvement in either group?
The answer here, the surprising one, is C. Showed similar significant improvements in both groups. Despite the big difference in AF freedom, both groups felt significantly better overall.
Such an important finding. And finally, question 10, a sobering point on safety. What was the major complication observed in the LFM plus AAD group that was not seen in the CA group? Was it A, transitory ischemic attack, B, vascular access complications, C, sudden cardiac death, or D, myocardial infarction?
The answer is C, sudden cardiac death. Tragically, one patient in the LFM plus AAD group experienced an unexplained sudden cardiac death, highlighting the serious, albeit rare, risks associated with the antiarrhythmic drugs used in that arm.
That was a fantastic recap and challenge. Thank you so much for joining us on this truly deep dive today. We really hope this exploration has given you, our listener, a clearer, much more nuanced understanding of these important treatment options for atrial fibrillation when it occurs alongside obesity.
It's complex, but hopefully clearer now.
Absolutely. Until next time, keep learning, keep questioning, and keep diving deep.